Very good evening. ಎಲ್ಲರಿಗೂ ಶುಭ ಸಂಜೆ. I welcome today Dr. Subarna Roy sir to this talent search webinar series program on behalf of KSTA, on behalf of all the teachers and students fraternity. Thank you very much and accepting our invitation, sir, and being with us today. Thank you very much, sir. Hearty welcome. Also, I would like to welcome our technical team, non-technical team, teachers and students who are with us today to today's session. Excuse me, which is related to infectious diseases, importance and essentials of investigation outbreaks of infectious diseases. So before starting today's session, I would like to give a brief introduction about sir. Public health, Dr. Subarna Roy sir is a public health microbiologist and molecular epidemiologist by training. He prefers to be introduced as an ordinary citizen of India. He is the director of ICMR, National Institute of Traditional Medicine, Belgavi, which is in Karnataka. Dr. Roy has worked extensively in several vulnerable communities on molecular epidemiology of infectious diseases, outbreak investigations, and disaster management. He is the founder scientist of the Model Rural Health Research Unit of the Department of Health Research, Government of India, established in the aspirational district of Raichur, Karnataka. Dr. Subarna has been working at the interfaces of community and laboratory, modern medicine, and Ayush, codified and non-codified systems, and research and research policies. He has more than 120 publications, 3 patents, and has operated more than 30 research projects funded by national and international agencies that include CDC and WHO. He is awarded with the University of Gold Medal, topping with the University of Burdwan in West Bengal in the year 2007. And Dr. Subarna Roy went on to receive KSTA Fellowship of Karnataka Government, Major General Sahib Singh Soke Award, the highest award of ICMR for work on infectious diseases, and the SS Misra Memorial Award from the National Academy of Medical Sciences, New Delhi. Dr. Roy has graded 12 scholars to the award of PhD degree so far. His present focus is on integrating traditional and modern medicines for public health outcomes. At 49 years, Dr. Roy is one of the youngest directors of ICMR institutes across the country. With this very short, brief introduction, I welcome you once again, sir. The floor is yours.
Thank you.
Thank you very much.
Thank you, sir. Thank you. Thank you. Oh, shall I begin my presentation? Am I audible?
Yes, sir.
Okay. Thank you. Thank you so much for the kind invitation. And at the onset, let me thank KSTA for giving me this opportunity to come and speak to the students, particularly the very young students who have come to attend this webinar. And as described during my introduction, I actually viewed science as a kind of an adventure and a story. And I'm going to share some of these storytelling activities which happen to be a part of my own activity that I did. And the purpose is to motivate you and see that you all understand what outbreaks are and how they're investigated. And if it interests you, then you can take up this as a very important career option in your lives. So what I will do is that first I would like to greet you on behalf of my institute, which is located in Belgavi, and I will cover what an outbreak is, how it is defined, how outbreaks are investigated, why they are investigated, and a few examples, particularly with gastroenteritis. If I get time, then with diphtheria, and then how these examples or these outbreak investigations can lead to research, how it can lead to publication, how it can lead to careers, and how it can lead to policy and public good. So basically, it is intended for the students, very young researchers like you all, and the faculty of some of the colleges and academic institutions, encompassing various disciplines like microbiology, biotechnology, epidemiology, public health, and it is intended to build the capacity and exposure to translational value of the field and laboratory research. In case you have any difficulty or you have a break in the communication, just stop me and let me know.
Sure, sir. Sure, sir. Thank you, sir.
So, see, how often do we come across these kind of headlines? So, these every now and then props up in our newspapers, in TV channels, and these have become a very routine kind of thing for all of us. And recently, as you know, there were Nipah outbreaks in Kerala. A big surge of dengue cases are going on in Bangalore. So these are very routine things that has happened or are happening to us. And I'm not going to talk about coronavirus because that is something which everybody knows. But then there are talks about the disease X, which might be the next global pandemic also. And every country, including India, is trying to get ourselves prepared for such kind of eventuality. But then we don't want to be underprepared. We want all of us to be prepared. And since we are talking about the future, I think I am speaking to those people who will be actually doing work in these kind of lines in the future. So that is the importance of this particular topic for you and I and for everybody else. So first of all, let us understand what an outbreak is. An outbreak is a sudden rise in the incidence of cases of a particular disease. The occurrence of an illness in a frequency that clearly exceeds the normal expectancy in a particular place, among a specific group of people or subjects, in a particular period of time. So you have to understand something which is aberrant, which is not a very normal happening in terms of number, is an outbreak, provided you have a proper place, proper people or group or subjects, and at a proper time. Some of the key definitions, I think most of you know because of the pandemic, is that pandemic, as you all know, that epidemics that spread over continents over time, and epidemic is something which starts with an outbreak which is much smaller in nature, but then it becomes wider in a geographic area over a prolonged period of time. And there are healthcare associated infections in which it occurs in patients or healthcare workers as a result of healthcare interventions. So it is mostly because of the healthcare interventions that we do sometimes some treatment or some kind of practices that result in infections. Hospital acquired infections, often also called nosocomial infections, are acquired during the stay in the hospital. When the patient had come to the hospital at the time of admission, they did not have it, but they acquired that disease in the hospital. So that is called hospital acquired infection. And healthcare facilities, we refer to all the hospitals, nursing homes, the clinics, OPDs, rehabilitation centers, etc. Now, how are outbreaks identified? These are identified by doctors, clinicians, nurses, sometimes infection control professionals, sometimes any medical staff. Very often they are identified by microbiologists, the laboratory personnel, sometimes by even patients or families of patients. Say, for example, you have this conjunctivitis, that redness of eyes, no, very frequent. Last few months also there were quite a number of cases. So you see there is somebody somebody gets infected in the family. Then don't we say, "Acha, we have got one, so we may likely to get in the other people as well." So you identify it even within your families as well in many cases. Sometimes it is researchers who identify it while doing their activities or research activities. They stumble across a certain upsurge in cases, which is different than the normal. Sometimes in hospital or in community-based surveillance programs, sometimes surveillance programs that are routine in nature that keeps on happening, and then they find a sudden surge or spike in some of the cases. So that also becomes an outbreak. Sometimes an unusual agent, a site, or a host may sometimes also play a role in identification of outbreaks. Basically, these are the people whom I prefer to call as disease detectives. So how these detectives work? So and why do they need to investigate an outbreak? First and foremost, we need to prevent or reduce additional cases. Whatever has happened, because that is how the outbreak has occurred. But we need to restrict that outbreak. Then again, we have to prevent future outbreaks so that it does not occur or reoccur again. Sometimes to assess or evaluate prevention interventions. Sometimes you may think or you may come up with some kind of an innovation or a technology or a treatment which might actually help in prevention of the outbreak, so that can be evaluated during these outbreaks. How many tests and how many different treatments were evaluated during COVID, you all know. Then learning more about new diseases. If it's a new disease, as it happened with the coronavirus, so we learn more about it as we learn every day from whatever happens with that particular disease. Then sometimes we learn more about the disease itself. There is also a requirement to reassure the public, because panic sometimes creates more problems. So public has to be reassured. We have to tell the people that things are being done, diagnosis is being done, treatment is being investigated. If there is not there, if it is available, they are being given. So these are kind of measures, things that needs to be done. And we have to also minimize the social and economic disruptions. One of the biggest problem with the COVID-19 outbreak was the disruption of the entire economic and social activities that happened. There are several negative effects that are linked to the outbreaks. Of course, morbidity and mortality. Morbidity means your afflictions, you get affected. So the number of people who gets affected are very high. Mortality is the deaths. So there are likely to be deaths in many important infectious diseases. Sometimes there is prolongation of hospital stay. So sometimes the stay at the hospital becomes more, which also gives a financial burden to the people and their families. And sometimes additional procedures also are involved in that. There is increased cost and often bad reputation or whatever, be the hospital or the healthcare system or even the management itself. So these are all negative effects that outbreaks cause. Now there are always certain constants which come along with outbreak investigations. These are, there is always an urgency to find the source and prevent cases. For the corona, we have still not found the actual source. But there has always been attempt to prevent cases. There was a very big urgency and attempts to find the source also, but then we have still not reached a definite conclusion. There is always pressure for rapid conclusions. Mostly it is political, even sometimes from the public health perspective also, because once we reach the conclusions, then we can start intervention measures. Sometimes there are pressures because of legal and financial liabilities. Sometimes there are pressures and delays in testing, because if people do not get diagnosed on time, then their treatment also gets delayed. So basically, these disease detectives are like this Daya and the CID group. Those of you who have seen this serial on Sony TV will know how they had certain protocols. They would see first when the patient died, then what was their body temperature. So like that, there are several steps which are involved in an investigation of an outbreak also. First, we have to determine that the outbreak exists, the very existence of an outbreak. You have to confirm the diagnosis. So what it is, what outbreak it is. You have to define a case. Which cases do you fit into as that disease? Then you have to search for cases, where these are occurring, how they are occurring, when they are occurring. Then you have to generate certain hypotheses and descriptive findings. Then you have to test this hypothesis based on an analytical study and the data that you have. And then you can draw conclusions on them. And then you can compare the hypothesis with the established facts, and you can communicate your findings. So these are the broad outlines or the broad steps when you investigate an outbreak. As I told you, it is like a story. So you are like you are in an adventure. So even if you are doing an investigation or if you are reading even a case, so always view it in these kind of parameters, so that you are able to not only establish a good outbreak, but also have a fair bit of knowledge about it, and it will help in prevention, adopting prevention measures. Now, the first one, how to establish an outbreak. As I said, key that you have to first define the outbreak. It is an increased incidence in a given place and time in a particular population. So naturally, you have to first show that it is aberrant from the normal. Then what you need is a numerator and a denominator. The numerator is the number of cases that you are having at that particular time, and the denominator is the size of the population where these cases are coming from. And along with this, you need a collection of information over the time, and you need a baseline. So what was the normal? So that also you need to define. So basically you have two things. One is the numerator, the number of cases, and the denominator is the size of the population you are interested in. There can be sometimes pseudo outbreaks. What are these? These are actually apparently outbreaks but not actual outbreaks. This happens when you have artifacts in the numerator. Say for example, increased awareness. Say for example, today in my place, I don't see any scab typhus cases. But today and then for the next say 30-40 days, I have a campaign where I increase awareness about scab typhus, and then I test them, and then I find quite a number of people coming for testing and then testing positive. So then there is a of course a increase in the recorded number of cases. But that may not be true, because that might also be there earlier also, but we never knew, or we not testing them or not identifying them. So these kind of things can happen. Sometimes there is reporting of prevalent cases as incidence cases. So there is a difference between prevalence and incidence. Incidence is when the cases occur now, new cases, whereas prevalence is already existing cases. So sometimes when these existing cases are actually added with new cases, then there is an increase in the numerator. So that sometimes will lead to erroneous results. Sometimes there might be laboratory error, there might be wrong diagnosis or whatever, so that can also lead to a false uh, alarm as far as outbreaks are concerned. There can be variation in the denominator also. Say for example, when the population denominations are rapidly changing. Say for example, with migration, if you are doing a study in say a place like Goa, where you have a lot of tourist people coming in, and then a lot of people going out, so you may not have a very constant denominator. So that time also the results may change. So it can happen with hospital patients, it can happen with migrants, it can happen with refugees, it can happen with expatriates, so with many other conditions as well. Then you have to confirm the diagnosis. So this is done by identifying three kinds of cases. One is a possible case, that is those events that can possibly be considered as the cases following certain investigations. Then there can be probable cases. Here you are talking about those that are compatible and are clinically falling into that category. And then comes the confirmed cases, where it is the cases are actually supported by a laboratory test, and then they are confirmed to be affected by that particular disease. This is a very important slide where we have a line listing of an outbreak. By line listing, we generally make a table or a chart of a number of time, place, person, outcome, and laboratory results. So if we make that over a period of time, then we come up with a line listing, or what we also call as an epidemic curve. So that gives a lot of information for us to identify the outbreak. Then what we do is that we count, divide, and compare. We call it as CDC. Count the aggregate cases in the line listing, what I just said in that chart, by characteristics, that is by age, by where they are living, by their sex, and then we see how many, say how many adults are affected, how many children below 5 are affected, how many adolescents are affected. So these will give a lot of information about the disease in question. Then we divide the number of cases by the relevant denominator. So if it is children, so then how many children were there in that particular place or in that particular community? So you have to compare with the respective denominator. And then we compare with different incidence rates across the groups. So we can compare, see whether the children are affected more, or the elderly are affected more, or the middle-aged people are affected more. So this kind of information also will come from that line listing. Then you generate a hypothesis using this time, place, and person perspectives. So you generate that epidemic curve, you generate a spot map or an incidence by area. You also develop the incidence by age, sex, etc. And you can have other question and outliers also in that. So this is how a spot map is generated. You can see on the right of your screen that there is one road, and on the road side there are quite a number of houses that are mapped, and then we try to map how many cases are there in each of these houses. So that gives a fairly good idea about that particular place where actually the outbreak clusters are located. So that gives a very good indication in the investigation of outbreaks. Person also, as I said, I'm not going into details again. So this is again that your by age or by sex group and all, you count and then you divide and you compare, and then you generate some questions, key open-ended questions which are administered to case and patients only. So these are all kind of qualitative studies that are done by asking several questions. Sometimes we have focus group discussions, sometimes in-depth interviews to find out what the possible sources from which they might have got this infection, or how the epidemic spread in that particular area. So so you generally try through these questions to identify what is common in all the cases. If there is any event in which they participated, so there might be cases of GE gastroenteritis. So it is quite possible they might have attended some yatra or some other program somewhere, and then all these people got infected. So you have to go to that point source where actually that yatra occurred and who cooked and what was cooked. So these are kind of things that you may be led to by asking these questions. Any place commonly they might have visited, or maybe a particular borewell source or a particular handwell they might have used, and any behavior they might have in common. So these are kind of questions that will help you in understanding how and from where the infection might have spread. So these are the basics of the outbreak investigations. So what I will do is that I will try to take you through with some of the examples that we did, so that will help you in understanding how these principles were used in various kinds of outbreak investigations and how the story comes out of that. So this is about a twin outbreak of gastroenteritis that happened in rural Bijapur way back in 2012, more than 10 years ago. At that time, clinical cases of diarrhea and dysentery were common in Bijapur and the surrounding areas, but there was very little scientific literature available on them. Almost nothing was known about the status of the enteric disease in the rural areas of the district at that time, except there was only one report of cholera from Bijapur, again way back in 1996, and after that nothing was known about this particular disease in that region. So there is a place called Haranal. It's a very small village. Uh, on 20th August 2012, I have given a spot of that place in the map of Karnataka. You can see there. So it's a village under Konnur PHC of the Mudabilal Taluk, about 100 kilometers from the administrative headquarters of Vijapur. What happened here is that in this population of 1086, 85 cases of watery diarrhea was reported from this particular village on this 20th of August. The DSO team there, the surveillance officer, he visited the area on the same day, and he tried to investigate the outbreak. He conducted house to house survey. He collected water from the only drinking water source that is available in that village, which is a well, and he made arrangements to supply safe drinking water through tankers. You can see one tanker shown on the right, so that people do not take water from that particular well. And then he distributed halogen tablets and waters among the people, and health education regarding personal hygiene and public hygiene were imparted. A temporary clinic was also opened in one of the Anganwadi uh, buildings, and the healthcare workers actually were equipped with intravenous fluids, and an ambulance was stationed there temporarily to transport the serious patients to PHC. So very well done actually. The school was converted into a temporary healthcare facility. You can see here one child is lying there, and they are giving a IV from the school. So these kind of arrangements were made. On the next day, another 55 cases were reported. Fluorination was carried out on the water sources, and 5 stool samples were collected from these admitted patients and were sent to the referral center. And then from there, actually, it came to the Belgaum Institute of Medical Sciences for culture and sensitivity. So the IDSP laboratory is located in Belgaum, and it was through their lab that the samples came to us, and then we tried to test the samples using microbiological and molecular techniques. On 24th of August, our team, including myself, we visited Harnal and we interviewed the residents, healthcare workers. The DSO team also accompanied. When I talk about interview, you can understand the kind of steps that I told you about. What are the sources of drinking water that they use? If there was any common event, function or jatra where they might have attended. So these are kind of questions that were asked. Then water samples were also collected from these wells as well as from the end users from their matkas inside their homes. And then we met various people in that particular area, tried to understand what was happening. And what we found is that, well, you can see in this particular picture, on the right hand side is the well, and on the left hand side you can see some sewage lines which are coming out from the building from the on the left side, and these are actually toilets which are constructed. The entry is from the other side. These pipes were actually discharging soil into 5 meters, within the 5 meters of the well. So this came to our notice, and it was said to be covered with cement concrete on the 22nd of August. And as you can see here, one dog is also found there. So quite a number of domestic and farm animals were found in that vicinity. And importantly, villagers reported having rains on the 17th and 18th of August after a very, very prolonged dry spell. So this is the epidemic curve. As I said, the number of people who were affected, and then over the period of time. So as you can see, there were no cases on 14, 15, 16 to 19 August. And then suddenly on the 20th of August, there is a large number of cases. Then slowly it came down and disappeared. So therefore, the outbreak was established, because it was certainly a upsurge. It was more than the normal, and then there was an outbreak of GE, definitely. So 201 persons were affected totally, which gave an attack rate of 20.94. So that means around 21% of all the people living in that particular area were affected. This is the age group wise how people were affected. So you can see that the children below 5 and children above 15 were affected. It was also the age group between 5 to 10 and 10 to 15. So all the age groups were actually affected. So it is not that it was coming only to certain children, but it was there in almost all. Meanwhile, in the laboratory, we identified Vibrio cholerae O1 Ogawa, which is the strain of it, and out from 3 out of the 5 samples, it was isolated, and they were found to be positive for the cholera toxin gene CTXA, and TCPA is a toxin co-regulated pilus. So these were actually toxin producing cholera strains, pathogenic strains of cholera that was established in the laboratory. We also did other molecular tests for identifying the pathotype of this particular strains. We also tried to rule out other causes of diarrhea like rotavirus by using other tests like ELISA. We also did an antibiotic sensitivity pattern of these particular isolates, and as you can see, the green ones are those antibiotics in which it is sensitive, and the red ones are those where it is resistant. And as you can see, ampicillin, nalidixic acid, cotrimoxazole, nitrofurantoin, these were all the antibiotics that the particular strain was resistant to. And we also tested the drinking water samples that were collected from this well, and we found samples collected on 31st July, 20th August, and 24th August to be contaminated with MPN, which is the most probable number of fecal coliforms which are present within the water samples to be more than 10 cA. Like means it starts and then it goes down and it stops. If you have multiple peaks, then that means that actually it is spreading from person to person or from different places, not a single source. So here in this particular case we had one peak, so that means it was a point source where it started within a big number and then it subsided and came down. So that is what it talks about. And since all age groups were affected, it is most likely that this was the first time that the cholera had hit the village. Normally, what would happen is that if a new pathogen comes, then most of the people in that across age groups get affected. Whereas if there has been a repeat of the same strain coming all over again, then those who have already acquired immunity will not get affected that much. Only the children who are not immunized will get more affected. So that again will tell the age specific rates will tell whether it's a new outbreak or it is something which has been exposed earlier. Now, since the only source of potable water was in the village, was found to be contaminated with fecal coliforms, as I showed in my tests. So it is likely that the well water got contaminated with Vibrio cholerae just before the 20th of August, and it triggered this outbreak. Now, there was evidence of fecal contamination in the well prior to the outbreak, which might be due to the discharge from this open sewage pipes. You remember that I showed that picture. So there was an open sewage line which was going through 5 meters within that particular well, and there might be sewage. The sewage might have seeped inside the groundwater, and because of the presence of animals and all, lot of fecal samples also will be there on the ground. And then there were rains. So just before the outbreak started, there were rains. So the rain water might have taken this fecal matter also seepage to down to the groundwater, and the well might have got contaminated from there. So a villager might have visited a nearby cholera hit place prior to the outbreak and might have carried this pathogen to Harnal, where it was discharged through this particular toilet and the sewage, and it got contaminated through this rainwater, and the entire well actually got contaminated. Then we tried to again do some interviews, and we found that
Seems we lost you. Are you there, sir? Are we connected, sir? Sorry, sir, we lost you. Just 30 seconds.
am I audible?
Yes, sir. Audible, sir. I think there was a network issue. We lost you before.
I think some issue with the network.
Yes, sir. Yes.
Is it okay now?
Yes, sir. Yes, sir. Fine, sir. Please go ahead.
Yeah. So as I was saying, the inference was that this anemic child brought cholera to this village from somewhere in Talikoti, and he came back to Harnal on 16th of August, and perhaps it was through his feces from from this toilets that actually seeped into this well area, and it got contaminated. So, and that is how the outbreak spread. So then that led us to Talikoti, because this particular case, which is the index case, what we call the first case in that particular village, came from Talikoti. So we went to Talikoti, which was 90 kilometers away from the Bijapur headquarters. And it is a much bigger town with around 31,000 population. And interestingly, we found that there had been quite a number of cases of watery diarrhea reported to the district surveillance unit between 8 July and 27 July, just preceding the Handal outbreak. There were two stool samples which were collected from inpatients and was also identified as the same toxigenic uh, Vibrio cholerae O1. So it was again isolated and it was identified by our institute in Belgaum. And we visited on 24th August along with the DHO team, and then we carried out further investigations through the verbal autopsy of the health workers, the patients, the residents, and the staff of the water treatment plant. So again, the municipal water treatment plant was supplying the potable water to most of the town, but that got dried up because of the drying up of the Krishna water feed. So there were some bore wells and hand pumps which were located in several places that were being used as alternative drinking water sources. Interestingly, a new borewell also was dug up adjacent to the water treatment plant just before the outbreak. And 6 of the 6 water samples collected from various sources during that time was reported unfit for drinking. Now you see this particular epidemic curve. Here you can see it is not a single source outbreak, it is a wavy curve. So that means it was spreading from multiple places, and even sometimes from person to person it might be spreading. But here the number of cases were lower because the attack rate was much lower because the population size was much bigger. So the denominator was much bigger, whereas it was attack rate was 21% in Harnal. Here it was only 0.38%, and only 101 cases were reported in the 20 days that the outbreak lasted. So this is the difference between the Harnal and Talikoti, but most likely this Talikoti strain only went to Harnal and caused the outbreak. Here also we did the age group specific analysis, and here also we found that the most of the age groups were affected, and the same strains were isolated. This was the same antibiotic sensitivity pattern that we obtained, so that led us to believe that it is the same strain which actually moved from Talikoti to Harnal. So these are some of the investigation photographs that we did. So our inference was that this outbreak was comparatively smaller but longer, and the attack rate was also much lower. All age groups were affected. It was not a single source outbreak as was thought by the locals. They closed down that newly constructed borewell, but that has nothing to do with this particular outbreak because it was happening from all over the place. The index case in Talikoti could not be traced. Who brought the cholera in Talikoti was, however, could not be traced. But it was apparent that the people who were infected did not belong to a single group, but scattered all over the small area within the town. The scarcity of water also compromised the personal hygiene of the residents, who shifted to alternative hand pumps and bore wells for domestic water consumption. So naturally there was a crisis of water, and then hygiene was a little bit compromised there. And the Harnal outbreak was caused from a carrier from this Talikoti. So as you can see that we came out with a couple of publications from this particular study. One was entitled Twin Outbreak of Cholera in Rural North Karnataka. So it came in the Indian Journal of Medical Research. And then another came in Japanese Journal of Infectious Diseases, where we actually found out the characteristics of that particular cholera strain that was circulating in this particular place. Then subsequently, there were a lot of more cholera cases identified in that particular region. And in fact, we were the first to find out the Haitian variant of cholera from among these isolates. And it was the first report from South India of this particular variant. I'm not going into detail of this variant, but it holds a very significant epidemiological importance. So similarly, we had been giving services to the various districts in Karnataka. So we used to get quite a number of requests for identification and characterization of the various outbreak strains from the various districts in Karnataka, and we do carry out and monitor their sensitivity and their characteristic patterns. One thing I would like to inform you, mostly the students, is that you must understand the use of antibiotics, particularly if you can see here. So this is a view of the Vibrio cholerae strains antibiotic sensitivity pattern isolated from Hubli in 2010. So you can see the green ones are those antibiotics to which it is sensitive, so that will work. And those which are in red are those antibiotics that will not work. So this is in 2010. So from Hubli, if you see more, this is the Vibrio cholerae strains from Belgaum at the same time. You can see the difference. The Belgaum strains are much more resistant to many antibiotics than the Hubli strains. So this is how the antibiotic resistance of the same organism, same strain, vary from place to place. Hubli and Belgaum is just 100 kilometers away, but still at the same time, so much of difference in the antibiotic sensitivity patterns. Now you see in time, this is Vibrio cholerae isolated from Hassan in 2010, sorry. So you see here it is even more resistant, with the yellow ones being intermediate resistance. The red ones have increased. So here the resistance of these particular strains from Hassan is much more than those of Belgaum and Hubli. But this was in 2010. Now this was in 2014 from the same place in Hassan. So over time also you see in just 4 years how much resistance has increased. So if somebody, normally good thing is that for Vibrios, cholera and all, you don't require antibiotics. They are self-limiting. If you manage well with intravenous fluids or even oral rehydration therapies like your Electral and other available commercial electrolytes, then you will be able to save the patient. But there are certain cases, some infections, and where you need to give antibiotics. But if you get resistance patterns like this, you see in the lower portion here, these strains are resistant to almost all the antibiotics that we have at our disposal. So what kind of treatment are you going to give to this kind of strains when you find people having this kind of infections? This is a major problem that the infectious disease world is facing. It is mostly because of the misuse and improper use of the existing antibiotics that we have. We are creating more of resistance in bacteria than actually we are kind of mitigating the problem. We do not have too many antibiotics in the pipeline, also new antibiotics to take care of this. And therefore, this is an important message that all of us need to spread. The use of antibiotics has to be very judiciously done, only in times when it is absolutely required. Otherwise, there is no need. So this is an example that I thought that I would share with you. There are several examples with other diseases as well, but then it will take a lot of more time. So I am not going to go into other examples, but I think this should be good enough for you all to at least have a flavor of what an outbreak investigation is, how these are done, and how this kind of stories are written. You can make it as a story that you would like yourself to kind of make, and then that is what you transform into scientific literature and you publish them, and it not only benefits you, it benefits your institution, it benefits the public at large, it helps the state in managing infectious diseases much better, and most importantly it creates a kind of environment for you to flourish and save our country, save our nation from uh, any possibility of emerging infections that might come uh, to plague us in future. Thank you.
Thank you very much, sir. I request students and teachers, if there are any questions, they can post in the chat box so that you can speak to directly, sir. If you raise your virtual hand, we will unmute you. You can directly speak and clear your doubts. Sir, as of now, there are no questions they have mentioned.
Yeah. Any question? Anybody wants to ask anything, please? of now, nothing.
Sir, who is responsible for the policy or guidelines preparation during the outbreak or pandemic, sir?
Yeah, it's a very relevant question that you asked. Actually, I had one slide on that diphtheria presentation. So actually, we only write this is a policy brief that we submitted to the government of Karnataka. Once we identified a lot of cases of diphtheria, we did again this kind of investigations, and we came up with certain ideas. Is that for diphtheria, it is not only identification and antibiotics. You have to give the anti-diphtheritic serum because the toxin that is released, that needs to be neutralized. So this availability of anti-diphtheritic serum was very limited. So we gave suggestion that for endemic areas, there must be availability of antidiphtheric serum, number one. And secondly, it proved that we are not complying with the vaccine coverage. So this was a very important suggestion that was given. And I am happy that actually in Mission Indradhanush, subsequently this uh, vaccination came, the vaccination drive came, and people were more immunized. Some improvement is there, and in fact, now we have started one research in Raichur district, where this mission Indradhanush was launched to find how much actually it has been effective in combating the disease. So that is something which I wanted to tell. So yes, it is we only who have to actually uh, inform whatever we publish or whatever we come up with to the relevant state government officials, and they do act on that. If they get hard evidence, scientific evidence, they do act on it. But only problem is that we do not often generate enough evidence for impressing upon them to act.
Thank you very much, sir. What were the challenges you have faced during the field visits, sir, during pandemic and outbreaks, and how you have overcome it?
Uh, so it depends on place to place actually. So I have worked during the 2005 uh, Mumbai floods also, when there was an outbreak of dengue and leptospirosis together in Mumbai. So Mumbai was completely different from what we work in the rural Karnataka region. And similarly, when I worked in the islands of the Southern Nicobar group of islands, so there it is entirely different. So situations are completely different in different places. But perhaps that is what means keeps us learning every day. And different challenges come up. Mostly, once you are dealing with infectious diseases, first priority is that you yourself do not get infected. So that is something which you have to be careful about. But then it normally doesn't happen because once you are in the field, you get exposed to an extent. So whatever precautions you take, there will be certain amount of risk. But importantly, you should not get afraid of these risks. If you are dealing with a level 2 pathogens, then nothing to worry about. If you are dealing with a level 3 pathogen, then of course things will start becoming more serious. And of course, with cases like Nipah and all, you need to be extremely careful, because here the mortality rates are very high. So, so it will depend on the place and the organism that you are dealing with.
Thank you very much, sir.
Thank you. My
If
pleasure.
any other questions, I request students or teachers, they can post or they can raise virtual hand. If there are no questions, we will formally end the today's session. Siddhegowda, any questions?
ಸರ್ ಚಾಟ್ ಯಾವ್ದು ಕ್ವಶನ್ಸ್ ಇಲ್ಲ ಸರ್, ಚಾಟ್ ಬಾಕ್ಸ್ ಅಲ್ಲಿ ನೋಡಿದ್ರೆ.
ಯೂಟ್ಯೂಬ್ ಚಾನಲ್ ಅಲ್ಲಿ ನೋಡಿದ್ರಾ?
ಇಲ್ಲ, ಅಲ್ಲೂ ಯಾವ್ದು ಇಲ್ಲ ಸರ್. ಬಟ್ ಇಲ್ಲಿ ಡೈರೆಕ್ಟ್ ಆಗಿ ನೋಡಿ ಸರ್, ಸ್ಟೂಡೆಂಟ್ಸ್ ಹೇಳ್ಬಿಟ್ರೆ ನೋ ಡೌಟ್ ಸರ್, ನೋ ಸರ್ ಅಂತ.
Okay. Sir, any career opportunities for science students other than?
Yeah, absolutely. Thank you for this particular point. Yes, at ICMR institutes, including our institute, we take quite a number of students, particularly for their dissertation work during their master's programs, We take people for PhD programs, we take people for postdoctoral programs, and even for custom training. So normally in our institute, we encourage people to come for training for 6 months minimum. So if they send it as a part of their coursework or their dissertation work, they can do it from their respective colleges or universities. Even if they, after their they get their degrees, maybe they're looking for jobs or waiting for some other programs, they can come on their own also. They can drop in a request letter. We have it on our website. They can download the form and they can apply. So but minimum 6 months we generally require. So we train them. They don't have to pay anything to us, and we don't pay them anything, but we generally train them and they become our extended hands. So through them we try to get many of our this kind of work done, and they get a immense experience, very good experience in not only laboratories but also in field work.
Thank you very much, sir. You did such a beautiful presentation for our students and teachers as well.
Right, sir. Thank
Simple,
you.
plain.
Thank you so much.
Yes, sir. Thank you very much, sir. We would
Thank
like
you,
to
sir. Thank you,
associate with you
KSTA,
in
for the
future also, sir.
opportunity.
Pardon, sir?
Sure. I'm saying thanks to KSTA for this opportunity. I always like to come and speak to students particularly.
Yes, thank you, sir. Thank you very much, sir.
Thank you.
We will have some physical programs also, sir, in Bangalore.
Sure, sure.
Near
I'll be
future,
more than
sir.
happy to help.
Sure, sir. Sure, sir.
Right.
Thank you very much, sir. On behalf of
Thank you
KST
so
and
much.
on behalf of all the teachers
Thank
and students, we would like to thank you very much, sir. We are grateful to you, sir. Thank you, thank you. Also, I would like to thank all the students and teachers who have joined with us today. And I request all of you to register for that mental health week from Monday, 16th October to 21st October. You can share it to others also, which is open to all. Thank you. We'll see you on Monday. Thank you very much once again.